Hi everyone, welcome back to the UWorld Nursing channel. My name is Samantha. I am a nurse here at UWorld, and I am so excited to see you all back today. Today's live is going to look a little bit different than our normal, typical Wednesday question drill. We're actually going to be walking through each step of making a concept map. So first things first, what is a concept map? A nursing concept map is a way for nurses and nursing students to plan nursing care around a particular medical diagnosis. So it's a common assignment that may be given to a nursing student as part of class curriculum or clinical paperwork from your shift in the hospital with your preceptor on a clinical day. So depending on what class or clinical you're creating a concept map for, it may be based off a real life client, a case study, or simply just an overall disease or disorder. So we can organize these concept maps a couple of different ways. We can do it by the 8 basic needs like comfort needs, safety, nutrition, and psychosocial needs, or we can organize them by our nursing intervention like diagnostics and labs that need to be done, patient teaching, treatment and medications, and that is how we're going to organize it today. So with that being said, let's get started. When you have to make a concept map, where do we start? First, you're going to start by selecting one singular disease process. For example, we chose schizophrenia for today's live. So we started doing these concept map lives a few months ago with hyperthyroidism, which is a relatively simplistic condition. However, we're moving up here to something a little bit more challenging with schizophrenia. I know you all are ready for a bigger challenge though, so I'm not worried about it. This is also our first psychiatric topic to do one of these concept map lives on. So it's going to look a little bit different than maybe some of our maps in the past. You're going to see the biggest difference in the diagnostic section because we're going to use some DSM criteria. Our nursing diagnoses are going to be a lot different, and a lot of our signs and symptoms will be as well because we're looking at more mental side effects and mental symptoms rather than all of the physical ones that we're so used to. So speaking of patho and how this stuff starts out, we're going to start on the left side of our concept map with our pathophysiology section. This is a great place to start for any concept map because we cover the etiology first, then we work our way clockwise through the intricacies of the disease process. So patho, I have a little start here star for you all. This is where we're going to dive into the genesis of the disease process at hand. So we're going to define schizophrenia here, which is going to be the inability to interpret or interact with reality normally, which I know that's really broad. We're going to get more into it. Reality normally. And so you all know, I am going to, after we're done here today, switch to a typed version of this, just in case anyone has some issues reading my handwriting. I do not take offense to that. But in this case, we're going to define schizophrenia as when a client is unable to interpret or interact with reality normally. So what this looks like is our expression outwardly is going to be abnormal. So outward expression will be abnormal. Another part of this is that our inward interpretation, how we interpret the things around us, the subliminal messaging, is also going to be abnormal. And when you combine these two things, what this looks like together is going to be abnormal emotional responses. All right, now patho is also a great place to place risk factors for a disease. In the case of schizophrenia, there's a couple of things that increase likelihood for this or see it passed down. So environment is a big one here. We also have brain chemistry, which we're going to talk more about when we get to our signs and symptoms section. Genetics plays a role. And another thing to include here is that cannabis use can actually be a risk factor for this in genetically vulnerable individuals. This includes both actual cannabis and synthetic cannabinoids. Alrighty, so that is going to lead us to our signs and symptoms because we are working clockwise here. So signs and symptoms are all the clinical manifestations of the disease process at hand. Here you're going to want to be as descriptive as possible. Make sure you list everything you can find about potential manifestations. The more the merrier. We want to be specific here. So the manifestations of schizophrenia are going to be split between positive symptoms and negative symptoms. So what do we mean by this? In the risk factor section, you saw that we put brain chemistry on the list. When we talk about brain chemistry, we're referring to the neurotransmitter of dopamine. So dopamine is responsible for movement in the body, and we talk a lot about that in our Parkinson live lecture, but it's also responsible for reward centers of the brain. So stuff that's in charge of controlling our feelings of joy, of motivation, of satisfaction. Clients with schizophrenia who have too much circulating dopamine are going to exhibit positive symptoms. When we say positive, we mean like extra, so on top of the baseline. Clients who have too little circulating dopamine will exhibit negative symptoms. So when we say negative, it's on the inverse side of our positive symptoms being extra. Our negative symptoms will be deficits. So in this case, let's start with our positive symptoms. I'll just put a plus sign. All right, and a couple of ones to go over here. So the first one is hallucinations. And I want to make sure we drive home the difference of hallucinations versus delusions. So hallucinations are based on the senses. So these can be auditory, visual, tactile, or olfactory, meaning what we hear, what we see, what we touch, or what we smell. Hallucinations involve things the clients think that they see or hear, touch, or smell. But again, even though what they're hallucinating may not be real, is probably not real, the anxiety that they experience from it is very, very real, which we always want to keep in mind, especially when it comes to our therapeutic communication technique. Now, the difference between hallucinations and delusions is those hallucinations were based in our senses. Delusions are based on beliefs and ideas. Examples of these are paranoid delusions, which would be if a client thinks that someone is watching or spying or trying to get them. Grandiose delusions are going to be clients who think they have power or wealth or status that's greatly exaggerated. These clients may believe that they're the king or queen of a small country. We can have our delusions of reference or our delusions of control. Delusions of reference make a client believe that an unrelated and external event has a special meaning to their life specifically. They may believe that a main character in a really popular book or movie is actually modeled after them, despite the fact that they've never met that author before, or they may interpret a greeting from a random stranger passing by to have a deeper meaning rather than just like a simple nicety. So that drives home what our difference between hallucinations and delusions are. I also want to talk about more positive symptoms. We're going to look at our disorganized thoughts and speech. Thoughts and speech. All right. So we have a couple different examples of this. We have our loose association. So these are very loosely related thoughts. They don't make a lot of sense in normal conversation, but they may be something like, I like when I see carrots. Orange trees are big. Sunshine is my favorite. Now, in the terms of a normal conversation, this is not really going to make a whole lot of sense, but carrots are orange. Orange trees are big. Sunshine, oranges grow in the sunshine. So they're very loosely associated, but again, it's not going to make a lot of sense in terms of a normal conversation. We can also see neologisms, which is simply making up new words that don't exist in the dictionary. We can have tangentiality, when a client repeatedly diverts from the topic of hand, going off on a tangent, so to speak, and it makes it really difficult to pull them back in to focus on the topic at hand. We can see word salad. This is pretty similar to the loose associations, except there's no association whatsoever. It's simply a bunch of words thrown together. Things like green, butter, day, singing, December, they have no association there. It's just a bunch of words thrown together. And we can also see something called echolalia, which is just when a client repeats or echoes what they hear around them, maybe what you said, maybe what another client says. It's just kind of like parroting what they hear you say. Alrighty, another thing to talk about are disorganized behaviors. Alrighty. So in this case, we have two different examples, or a couple different examples. We're going to have our catatonic state, or catatonia. This is an unresponsive, sleep-like state. The client may be sitting or standing in a strange and uncomfortable position. And we can also see irregular movement. So jerking, kind of twitching, abnormal from regular function. And now let's move on to our other side of the spectrum with our negative symptoms. All right, so those were the positive ones, which again mean we have too much circulating dopamine. The negative symptoms means we do not have enough circulating dopamine. So these are going to be our deficits here. We're going to see apathy as one. Apathy is just going to be like a lack in motivation, a lack in activities like maybe our ADLs, our daily activities, our hygiene activities. We're going to see clients who are asocial, meaning that they are socially withdrawn, not really interested in maintaining or striking up a conversation. Clients can also exhibit affective flattening. Alrighty, so affective flattening is just speech that's very flat. It's a flat emotional response, very curt, very brief, and without emotion. Clients may also have anhedonia, which simply means a lack of pleasure. Now, this may be something that they previously enjoyed. Maybe it was pottery, maybe it was tennis, and now they have an inability to get that same pleasure from a hobby they used to enjoy. Some clients will experience alogia, which is going to be a poverty or a lack of speech. And we can also see avolition, which is going to really manifest with a general lack of motivation. And where we're going to see this most obviously is going to be those ADLs, our brushing our teeth, showering, wearing clean clothing. A lot of times these clients are so wrapped up in these negative symptoms that they're not really able to do that at an expected level. All right, so moving on to our next section, we have our diagnostics and labs to monitor. Now, this section will vary greatly depending on whichever disease process you've chosen for your concept map. Diagnostics can be things like CT scans, X-rays, MRIs, especially for diseases and disorders of the neurological or the musculoskeletal origin. Some disease processes, especially ones that include the hematological system, the body's blood, or the endocrine system, are going to rely heavily on lab work to assess the extent of the issue. Now, mental health disorders are totally different. It's upside down from those things. They're diagnosed using the Diagnostic and Statistical Manual of Mental Disorders. That's often referred to as the DSM, or maybe DSM criteria is what you're going to hear. So for schizophrenia, this criteria includes psychiatric symptoms, how long they have persisted, and whether or not they've disrupted the client's regular, normal day-to-day life. So for schizophrenia, we're going to go through our DSM criteria for diagnosis, and we have a couple of different caveats here. So number one, we have to have greater than or equal to 2 of the following symptoms observed. So these have to be between delusions, hallucinations, disorganized speech, disorganized behaviors, or negative symptoms. So greater or equal than 2 of, and I'm going to use acronyms. So we're going to have delusions, hallucinations, disorg speech, or behavior, and negative symptoms. So we have to choose, or we have to have greater than or equal to 2 of the following that we just described. Our next caveat is going to be greater than or equal to 1 life area must be disturbed. Area disturbance. So this can be work, it can be our home life, our social life, maybe the ability for self-care. Our next caveat is going to be symptoms have to persist for greater than or equal to 6 months. We also have to make sure we're ruling out other mental health disorders. So we have to rule out, in this case, I'm running out of room, but we're going to rule out schizoaffective disorder, depressive, and bipolar disorders. So I'm just going to rule out other mental health probs. And lastly, number 5, we also want to make sure we can't trace any of these symptoms to a substance use disorder or a medical condition. So cannot trace to med or substance issue. Alrighty, and one last caveat for any clients with concurrent autism spectrum disorder or communication disorder that was diagnosed in childhood, they must exhibit prominent delusions and hallucinations that persist for greater than or equal to 1 month in order to be diagnosed. So this looks a little bit differently than maybe a more physical disorder that we did in the past, but that DSM criteria is going to be pretty specific on the things that are required to diagnose schizophrenia. Alrighty, so we're going to move on to our nursing diagnosis section. So this is potentially the most difficult part of the concept map. Nursing diagnoses use an organization called NANDA, who produce the official list of nursing diagnosis. You can visit nanda.org for more information for that full list, but a nursing diagnosis, to be full and complete, has 3 different parts. So the first part is that NANDA approved nursing diagnosis. So in our case, we're going to use feeding self-care deficit as our nursing diagnosis. Again, you can find that official list at NANDA. You can even use your nursing school curriculum. Sometimes a little bit of that is already included there, so you don't have to purchase anything else. But we're going to start out with our first diagnosis of feeding self-care deficit, which is something that these clients sometimes really struggle with. And it can kind of include feeding or self-care. It can be either or, it can be both. So in this case, we're going to move on to our related to section, which is part number 2. This directs that nursing diagnosis to what is actually causing the issue. So what's causing that feeding or self-care deficit? In this case, it's caused by maybe a lack of intake, or it can be caused by avolition, those kind of neglecting our ADL. So it can be either one depending on what your clinical scenario supports, what the case study supports, or even if you're just doing it on an overall disorder. So we are going to put our related to section, and that's going to be lack of intake. And in parentheses, I'll put another option, which would be avolition. Alrighty. So clients who experience positive or negative symptoms may really struggle to properly care for themselves. This includes maintaining food and fluid intake consistent with metabolic requirements. A client in the active phase of this disorder may be experiencing really strong delusions or really strong hallucinations that take them out of reality. They're so caught up in these symptoms that they're not going to remember to eat and drink regularly. On the flip side, a client may also be experiencing really negative symptoms. They may be completely apathetic towards their own needs. Avolition is a negative symptom we we mentioned that means neglecting those ADLs, having that lack of motivation, clients may just not have the gumption or the energy to feed and care for themselves while they're in the throes of these really, really tough negative symptoms. So far we have that feeding self-care deficit related to either lack of intake or avolition. Part 3 is our as evidenced by section. And what this is asking is, what is our clinical proof of this? So I'm just going to denote this as capital E by. So if you're making this concept map using a case study, look to your case study for clinical manifestations that support this nursing diagnosis. If you're making the concept map regarding a clinical shift, look to your patient-specific results, vitals, and statements as your evidence. Remember, we always want to be as specific as possible. So as a general rule, something like blood loss of 1250 milliliters is going to be a much stronger piece of evidence than just saying blood loss without any qualifying statement. Just as blood pressure of 88/45 is a better and more specific piece of evidence than just stating hypertension or low blood pressure. Here our evidence would be supported by something like weight loss of 15 pounds or whatever your clinical data is going to support. So as evidenced by weight loss of 15 pounds. Alrighty, so lastly, we string all 3 parts of this together, and it's feeding self-care deficit related to lack of intake or avolition as evidenced by weight loss of 15 pounds. In this case, we can do a couple of other different nursing diagnoses are also going to qualify for this. So we could put disturbed sensory perception related to delusions as evidenced by the client stating, "I am the King of England." We could use impaired social interaction related to asocial behavior as evidenced by the client refusing to speak. Other examples would be like disturbed sleep pattern related to insomnia as evidenced by client foregoing sleep for 30 hours, or risk for self-harm related to command hallucinations as evidenced by the client stating, "The voices are telling me to unalive myself." But a quick note on the risk for diagnoses, they're not considered as strong as ones that list a manifestation that is already occurring or has already occurred. We try to limit the risk for diagnoses to 1 to 2 per concept map, and on this one we only included 1. So good job so far, we're doing great. All right, and again, we are going to show a typed version of this before we head out today, so hang on till the end and we'll give you plenty of time to screenshot that. Alrighty, so next we have our nursing interventions. This is a section where we really get into the meat of the concept map. This is where we list our nursing interventions to help maintain homeostasis in these clients, prevent the condition from worsening, and really employ our therapeutic communication techniques. Again, it's important to be as specific as possible. Schizophrenia is heavy on our therapeutic communication and fostering trust with these clients. So in this case, our general nursing interventions are going to just be overarching. General nursing interventions are going to include things like fostering trust. Trust, I'm going to put it in all caps, is so important here. We build trust through frequent and short interactions. We also avoid touching the client to set those boundaries. And it's really important to be neutral. Why is this? So in this case, think about these clients falling into either the positive symptom end of the spectrum or the negative symptom end of the spectrum. They're either one way really far to the side or the other way on the other side. We want to meet them right in the middle. That's why we want to make sure we come in and we're trying to be neutral here. If we perform an intervention on the client, we want to explain that procedure step by step, give them small and digestible pieces of information at a time, and we want to start group activities in a one-to-one setting before we incorporate them into a larger setting or a group setting. So start out one-to-one environments before we put them with a larger group. Alrighty, just making a slow transition. And now we're going to look at our nursing intervention between our positive and our negative symptoms. So for our positive symptom, nursing interventions, we are going to want to make sure we manage active hallucinations. And how do we do this? In this case, we need to understand more about what's triggering this hallucination. So we need to ask direct questions about this. We would say, tell me more about what you're seeing. Tell me more about what you're hearing right now. What do you feel right now? What we want to do is prevent an escalation of emotion from these clients. We really want to monitor for heightened anxiety, any heightened agitation, and decrease the stimuli around the client. Now, this can look like removing them from a situation that maybe they find stressful, or providing them with a distraction, something like headphones, or a small and structured activity like folding a napkin, or organizing something can help to keep the brain focused on a task at hand. But we definitely only want to speak about reality. We never want to dive into the hallucination with the client. We want to try and ground them back in reality. So for instance, a client that says, I see spiders on the ceiling, they may ask you, do you see them too? A good response would be, no, I don't see spiders in the ceiling. What I do see are ceiling tiles, lights, and an alarm box. This grounds them in reality without stating, you are wrong, that is not true, there are no spiders on the ceiling, simply that you yourself don't see them. We also want to always assess these clients for thoughts of harming themselves, or especially if they're experiencing those command hallucinations that may be telling them that they're supposed to perform a specific action. Alrighty, we're keeping on with our positive symptom interventions. We just discussed managing hallucinations. We also need to manage delusions. All right, so in this case, remember that delusions are again based on beliefs or ideas. So this is going to include a lot of active listening, so saying back to the client some of the things you're hearing them say, and a lot of empathy, so sharing or relating with them. We never want to argue with the client about their delusions. We never want to tell them that is wrong, that is incorrect. It's the same idea as with hallucinations. We want to try and ground the client in reality, so we might in some cases just try to change the topic of conversation. Clients who are experiencing delusions often are pretty suspicious of anyone around them. So we want to take the opportunity to prevent any more delusions, take them back out of the picture. Think back to trust. If we are offering them some kind of food, we want to give them a canned or a pre-packaged option, essentially ensuring to the client, I haven't tampered with this, no one is trying to poison you. We also want to open medication packages in front of them. It's the same principle. Make sure they know no one's tampered with it, no one has sabotaged this. And then after they take the medication, we want to make sure we check their mouth, their palms, their pockets to know that they actually took the medication. All right, now let's switch to our negative symptom interventions. All righty. Nursing interventions. All right, so a little bit different here. Again, negative symptoms are our deficit symptoms, so the lack of that circulating dopamine resulting in the deficits. Interventions here might look like social skills training. This one is really, really important. All right, so giving them the tools they need to interact with others in a normal way, engage them in settings where they are only showing signs of readiness. So we never want to force them into it before they're ready. But once they start to show signs of readiness, maybe they're more interested in talking to people, we want to make sure they have some type of social skills training. We also want to help out with those activities of daily living. So making sure the basic needs are met, especially if they're unable to meet them themselves. And as with anything, we want to make sure we're giving positive reinforcement along the way. All right, it's all about baby steps. But we want to make sure we are therapeutically communicating, giving them some encouragement along the way. So that was a pretty dense section, but you all did so well. Way to go. Now we move on to our treatment medication section, which for schizophrenia will be pretty medication heavy. So treatments and medications is where we address the root issue of the disease and or disorder. While many medications will be nurse administered, most procedures are going to be performed by healthcare providers. Really here is where we get into the meat of what the healthcare team as a whole is doing to prevent these clients and their condition from deteriorating. So for schizophrenia, again, it's mostly pharmacological. These clients a lot of times require frequent hospitalization, especially if they're not medication compliant, if they have a limited support system, or if they're in the active phase of the disorder. So our two main generations or classes of medication are our first generation antipsychotics, referred to as typical, and our second generation antipsychotics, which we refer to as atypical antipsychotics. antipsychotics. So first generation includes our haloperidol is our most common one there. First gen, which again is going to be typical. And that one, haloperidol, is the one I want you guys to take home with you. In second gen, alrighty, these are going to be our atypical antipsychotics. Common examples of these will be, I think clozapine is one of the most well-known ones. We also have our risperidone. We have, and I always mess this up, aripiprazole. And olanzapine is a common one as well. Alrighty, so in general, we have a couple of different side effects here, but just in general, first generation antipsychotics are going to target positive symptoms with minimal effect on our negative symptoms. Second generation is mainly targeted towards those positive and psychotic symptoms, but it does have more improvement with the negative symptoms. Overall, second generation is better tolerated with a less severe profile of side effects. We also have long-acting injectables now available, which is a wonderful thing, which will really help to improve medication adherence and overall outcomes. And as part of clinical treatment, the nurse also needs to make sure we're ensuring fluids and nutrition, especially in either those negative symptoms or in an acute phase when our ADLs and basic needs are most likely to go unmet. So patient teaching, moving on over, what information as nurses must we ensure the client knows prior to heading home, prior to getting discharged, or just in general? So this may include what things are they going to look out for with certain treatments or certain medications? What lifestyle modifications do they need to make? So for our clients with schizophrenia, a lot of medication teaching is going to be required. Antipsychotics are very effective drugs, but they do have an extensive list of side effects these clients really need to know about. So our general side effects is what we're going to cover in our patient teaching. And these apply to the first and second generation, but again, typically that second generation is better tolerated. So our general side effects are going to be orthostatic hypotension. We can see those drops in blood pressure upon changing position, maybe when they go from laying to sitting or sitting to standing. Clients can experience distressing metabolic changes. And this can include weight gain. It can include an increased risk for diabetes mellitus. Cardiac complications include a prolonged QT interval. Clients can also experience an overall sense of sedation. They can suffer with sexual dysfunctions. We can also see the potential for seizures, unfortunately. And lastly, there is the chance of something called extrapyramidal side effects and anticholinergic side effects. And speaking of those, depending on what disease or disorder you choose for your concept map, there's going to be information that you feel like just doesn't quite fit into any other box. And that is a great use of the other box on the concept map. So in the case of schizophrenia, we're going to use this section to educate clients on the specific side effect profiles of each generation of antipsychotics, specific to something called extrapyramidal side effects and anticholinergic side effects. So they really need to be known. They can be quite distressing, so it's important that these clients know that this is something that they may potentially experience. So with our first gen, we're going to go over these guys. But we have our extrapyramidal side effects, or EPS. Now there's a couple of different things we can see from this. We can have something called acute dystonia. Now, what is this? This is going to be abrupt muscle contraction. So it often affects the muscles of the head and the neck. Typically, it's not dangerous unless it involves those respiratory muscles. We can also see akathisia. Ooh, I spelled that wrong. Excuse me. Alrighty, this is a general restlessness, a drive to move. It can result in fidgeting, pacing, or other repetitive movements. We can see pseudo-Parkinsonianism. which would be symptoms that mirror those of Parkinson's syndrome. These are typically temporary, but the client may assume a disturbance in gait, a general rigidity, or a tremor. If you remember when we talked about signs and symptoms and that dopamine is really involved in movement. It plays a big role in Parkinson's as well. So it makes sense that this is a potential side effect. And clients can also exhibit something called tardive dyskinesia. So what is this? These are repeated and unnatural movements that don't really coincide with normal movement. Clients may stick their tongue out in a strange fashion. They may grimace. They may repeatedly smack their lips, but important to associate this with EPS. Next are our anticholinergic symptoms. Oops, excuse me. All right, so in this case, you may have heard mad as a hatter, dry as a bone to describe this. We're gonna see urinary retention, clients can have dilated pupils, and constipation. So think mostly of our dry as a bone symptoms. Clients here are not going to be excreting as much as normal. No peeing means urinary retention, no pooping means constipation. So in this case, we're gonna put urinary retention, constipation, and dilated pupils. All righty. So a quick little caveat on this, the second generation antipsychotic side effects, typically the EPS and the anticholinergic symptoms are less marked in that second generation. Clozapine, though, specifically is one of these second generation meds. It does cause marked neutropenia, so clients will need to have their ANC monitored very, very closely. But that concludes our concept map. Way to go, you guys. Our last step is to check before submitting. You want to read over your concept map multiple times before you submit it. Some instructors will be willing to look at it before you submit, letting you know any weak areas that may need additional attention. You can always ask if your instructor is willing to do this. The worst they can say is no. So with that being said, we're going to go ahead and go to the next slide, the typed slide. In case anyone was asking, I'm so sorry if you could not read my handwriting, but go ahead, take your time, screenshot this, take it with you. It includes more of the notes that I may have spoken but did not write down. Thank you all so much for joining today. Again, this will be posted on our social media too, so if you want to go back and hear more about how I explained each different section, you are always able to do that. But again, screenshot this, take it with you. We're going to leave it up, save it for your future reference. I know we're in the middle of the semester really right now. I feel like concept maps are usually most popular at the beginning of the semesters, but let us know in the comments too what you want to see us do next. We've kind of covered the full spectrum now. We've done mental health, neuro, OB, peds, and respiratory. So let us know what condition you want to see us do next. Thank you so much for joining, and I will see you all soon.